This podcast represents the opinions of our hosts and their guests only. The content here should not be taken as medical advice and is for informational purposes only. And because each person is so unique, please consult your healthcare professional for any medical questions. Welcome to Once Shattered, Picking Up the Pieces, a podcast devoted to changing the way eating disorders and mental illness are viewed in our society. With your hosts, Jack and Linda Major and Ellen Bennett. Today's guest is Dr. Lucene Wisniewski. Dr. Wisniewski is an internationally recognized leader in eating disorder treatment and dialectical behavior therapy, DBT. With almost 30 years of clinical research and training experience, an adjunct assistant professor of psychological sciences at Case Western Reserve University, Dr. Wisniewski has taught hundreds of workshops and continuing education seminars around the world and has authored numerous articles in peer-reviewed journals and invited book chapters. Dr. Wisniewski has pioneered the use of DBT in the treatment of multi-diagnostic eating disorders, MED, and is a sought-after authority on this empirically founded method of treatment, providing consultation and training to clinics around the globe. She is the co-author of the MED-DBT Treatment Manual to be published in 2025 with Guilford Press. Dr. Wisniewski is the founder and chief clinical officer of the Center for Evidence-Based Treatment, which offers therapy, training, and consultation in evidence-based approaches to mental health conditions via traditional and teletherapy platforms.
Hello, everyone. We are so thrilled to be here today, and we're so glad that you're tuned in and listening to us because this is going to be a fantastic show. We have a wonderful guest who I'm going to introduce you to in just a moment. You just heard her bio. But first, I need to welcome my husband, soulmate, and best friend, Jack Major, and our dear friend and fellow advocate, Ellen Bennett.
Well, hello, everyone. It's great to be with you again. And just a reminder that this podcast are sponsored by our nonprofits, K&B for Answers, from Ellen Bennett, and the Emily Connection from Linda and myself.
Welcome. We're ready for another exciting continuing conversation.
Okay, so I've picked out a quote for today from the book The Way. It's called actually just Way by Dan Millman. And the quote is, "The secret of change is to focus all of your energy not on fighting the old, but on building the new." And I think that's a perfect introduction for Lucene Wisniewski. Welcome.
Oh, thank you. That really is a meaningful quote, especially when we are, our job here in the big picture is to help those suffering from eating disorders. And I think unfortunately, too often, people get stuck in the past, and that the way forward is to focus on the now and the future. So I appreciate that quote.
Yeah, I mean, that quote really resounded with me because we need to really focus on new treatments for people. We've been doing the same old for a long time, which has worked, for some people, but we really need to start thinking outside the box and working on different ways of approaching these patients.
Yeah, I agree completely.
Gives us the opportunity to look at the whole individual, the whole person, and respond accordingly and tailor treatments to the individual, which is exciting. Mm-hmm.
Well, I was struck by the disclaimer before we came on, which was about medical care and each person is unique. And I think that, to me, that's exactly why we developed, MED-DBT, is because each person is unique. There's not, unfortunately, maybe fortunately, because people are unique. The one approach doesn't help everyone. And I think that, thinking outside the box is exactly what we need to do to help people who haven't been helped by the standard treatments, which are fabulous, but only help half the people.
Yeah.
And so if you're one of those unique individuals, we need to work harder.
Yeah. 50% doesn't really. It's not a passing grade. So.
No. Excellent point.
Oh, Lucene, can you tell us how you became interested in eating disorders and the wonderful people impacted by them? And can you also share the MED-DBT model for individuals with eating disorders, how it's different from other models, and when you began to embrace it?
Well, those are big questions for me, and I think if I take the first one, how did I become interested? I often tell this story because I feel like when people, especially people who are younger individuals who are looking for their pathway, sometimes think that the older generation, have it all together and just always knew what we wanted to do. And that really was not true for me. I had a series of accidents. Accident is not the right word, but unexpected things that sort of led me to the field of eating disorders. Like I went to graduate school. I mean, even studying psychology was an accident. I went to undergrad thinking that I would study languages, and that didn't work out. And I ended up in a psychology class, and I was like, oh, this is really interesting. And so then I continued in psychology. And then I worked at NIH after undergrad, thinking that I wanted to be a research psychologist and only work in psychophysiology. And then I applied to graduate schools only in psychophysiology programs, but I happened to apply to the University of Pittsburgh, where their program was part of a clinical program. And when I went to that interview, I thought, actually the interview with the person that I wanted to work with I love her. She's a dear friend now, but I think she was on her way to vacation, and it was very short. And my ego was hurt, and I was like, I don't want to work with her. And then I found somebody else that I was more interested in working with, because I talked to somebody at the program, and it was Len Epstein, who was at the time studying childhood obesity. So that was how I even got into the eating field, right? It was an absolute accident. It wasn't a plan. It was me following my path, and then also paying attention to my responses to my path. This is back in the late 80s, early 90s. And then I got bored by it because I was like, eat less, exercise more, okay. And then I want to remind you that when I went to graduate school, I thought, I never want to see a patient. I don't want to work with patients. It's too stressful. How can I possibly do that? I'm in my 20s. Maybe I'm a sensitive individual myself, and I think I can barely figure out how to manage myself. How am I going to help somebody else? But then over time and with experience, I start working, as I said, with childhood obesity. And then I was like, I think I'm interested in this other thing. And I happened to be at the University of Pittsburgh when Dr. Walter Kay, who's now at UCSD, and Marcia Marcus who's sort of a leader, she still is a leader in the field, but she's retired, in binge eating disorder. And so I started working with them because it was sort of a natural extension of the work that I had been doing. And over time, I became more confident in my ability to help people. And then I started to see that there were people who needed more than they were getting, that the standard treatments were not helpful to all of the patients that we were seeing. And so on some level, in response to the first part of your question, how did I become interested? I then started to learn. I grew up in the New York, New Jersey area, the greater metropolitan area, where, the focus on body size and shape was really was baked into the environment. And I don't think I understood how much of that was disordered until I started working in the field. And so, again, I tell this story because I want people to understand that you can get to a place that is high in your career even without having a clear plan from the beginning. So that was the story of how I got interested in eating disorders. Should I pause there before I answer your next question, or?
No, go right ahead. Roll with it.
Okay. So the next part of your question then is how did we start to think about MED-DBT, which is also, to me, a series of accidental. I have to find a better word for that, but serendipitous maybe is a better word. Serendipitous experiences. So while I'm at the University of Pittsburgh, I decide to stay for my internship because my husband was in medical school and I wasn't willing to separate myself from him for my career. My family and my personal life has always been just as important as my career, and I felt like I needed to stay in Pittsburgh, and not like I was sacrificing anything because Pittsburgh was a fabulous training program. During my internship, which was now 1994, and I tell you this because chronologically it's relevant, the DBT, the book actually it's called CBT for Borderline Personality Disorder, the Marshall Linehan's seminal work, came out in 1993. So here I am in 1994. I don't know about DBT. I never even heard about DBT. And so Kelly Kerner, who is a clinical psychologist of renown in the area of now, because we were young at that point, was in my internship class, and we became very good friends. And she started telling me about DBT, and I became very interested in it. And again, remember, this is, we didn't have a lot of internet back then. It's not like I could have found it on my own. So I hear about it from Kelly Kerner, and then in my postdoc year, because again, I'm staying in Pittsburgh, and I do an NIH-funded clinical research postdoc on the treatment of eating disorders. I'm working with Marcia Marcus and Walter Kay. Marcia Marcus invites Marshall Linehan to the University of Pittsburgh to train us all in DBT. So now we're in 1995. This book has just come out, and people are starting to get excited about DBT. And I get intensively trained because I'm a postdoc, and frankly, because it meant that I didn't have to work for 2 weeks. I was like, I can go do this training and I don't have to see patients for 2 weeks. I'll do that. So it wasn't a planful thing. And while I'm sitting in this training, I'm thinking, wow, this is fascinating. Fast forward, I moved to Seattle for my husband's residency. We decided together that would be a good place to move. And eating disorder is my passion. And at the time when I moved there, there had been an eating disorder program at Ballard Hospital. It had just closed. And so there was no eating disorder facility you would believe this, in Seattle, Washington. This is 1997 now. Yeah. So Kelly Kerner says, why don't you work with Marshall Linehan? Now, again, I don't know that she's someone so famous. I'm like, oh, okay. So I have an interview with Marcia, and I start working with Marshall Linehan, which I do while I'm in Seattle, and I really learn DBT. But eating disorders is always my passion, right? Eating disorders is what I became enamored with when I was in graduate school. It's the thing that I feel most competent in. It's the thing that I feel most passionate about. And so I'm learning DBT, and I'm learning it obviously at the knee of the treatment developer, right? So I'm learning it the right way. But I'm always thinking, can't we use this with eating disorders? Like, isn't this something that could be used with the people that I want to work with? Okay, and then the probably the most serendipitous thing that if I wanted this to happen, I couldn't have planned it to happen. We now need to move. My husband's finished with his residency, and he wants to. We want to move back east because I didn't like being so far away from my family. And so we're going to move back east. And we had been in Pittsburgh, and we were trying to move back to Pittsburgh, but he was a public health service corps scholar, and there were no openings at that time in Pittsburgh. He says, well, what about Cleveland? And I said, Cleveland? Who wants to live in Cleveland? Remember, I'm a New Yorker, really. I'm from New Jersey, but from right outside of New York City. It's Cleveland. No one wants to live in Cleveland. All right, let's go look at it. So we look at it. It's actually a lovely. It gets a bum rap. Cleveland is a lovely place.
Yeah, it does.
But it just so happens. So we're going to move to Cleveland, and I call a colleague who used to work here, and he says, "Why don't you call these people at Laurelwood Hospital? They're interested in developing an eating disorder program." I'm like, okay. So I called them up. It turns out that they had all just been intensively trained in DBT and wanted someone to start a program that was both DBT and eating disorders. Now, again, I could not have planned that if I wanted to, right? So we move here, and then here because I've still been here now 25 years later. And again, plug for Cleveland. It's actually a very lovely place to live. And I start to think about how do we marry the DBT that we know with evidence-based interventions for eating disorders, because I am not somebody who thinks, oh, I know more, for example, than Marsha Linehan. I'm not going to adapt her work. I'm thinking, now, actually, let me back up just a tiny bit. At the beginning we moved here in 2000, and there had been some randomized controlled trials using an adapted form of DBT by Deborah Safer and her group at Stanford, which was getting good research results. And it was a fabulous intervention, but it wasn't for the people that I was interested in helping. It was for people who had binge eating or bulimia, but didn't have any other problems, no comorbidities. And in fact, if you looked at the exclusion criteria for the clinical trials, suicidality and self-harm meant that if you had those, you couldn't be part of the trial, right? So the people that I'm interested in helping are the people who have the multiple problems. And I thought, well, that model's not quite enough because it's an annotated form of DBT. And again, it is a fabulous treatment, but it wasn't for whom I was interested in helping. And this hospital that I was developing this program for was a tertiary care facility where everybody who was coming had already had multiple trials of outpatient, inpatient, residential, higher level of care treatment. And I felt like we needed to think outside the box. So that's where we started. That's really where we started to bring these models together. And again, because I don't, I feel like I am a research scientist at heart. That's how I started my career. It didn't make sense to me to change Marsha Linehan's model to treat eating disorders, but I knew from my experience that eating disorder behaviors were confusing to people who didn't understand them. And then I also knew that there were these treatments, at this time it's CBT, FBT comes later, that already have decent data. Why would we not just marry these models in a way that, now, of course, that's complicated and time-consuming, but the truth is, if you're going to help somebody who hasn't gotten helped by the standard things, what you're going to offer them is likely going to be complicated, because if they could have gotten better by the easy stuff, they would have already done so. So I'm sorry, that's a long story, but that is the story.
Fascinating.
Yeah, it really is. Yeah.
That's amazing. And I think it really goes to the point of how so much that's happening in the eating disorder field is kind of serendipitous, that we're really in this time period of realization and discovering what is working and what we can do differently and what we can do better. Okay, I am very interested. I could go on with your first conversation forever and ever.
Yeah, that could take up the whole hour.
Yeah. But the Center for Evidence-Based Treatment, CEBT, tell us how this came to be and more about what is offered and what are some of your specialties.
Yeah. So, I could certainly give you a lot of details about from starting that program for Laurelwood Hospital to now. But suffice, I'll give you the summary, which is, ran a program at Laurelwood Hospital for several years, an excellent higher level of care, meaning we offered partial hospital and IOP. Then ran the Cleveland Center for Eating Disorders after that with Mark Warren. I don't know if you've had, who now has been the medical director at the Emily program.
Yep.
We joined with the Emily program back in 2014, and I worked for them for a while. But I really love the how you can move quickly when you're a small organization. And perhaps if you ask my husband, he would also tell you that I don't like people telling me what to do, which is probably true.
My husband would tell me the same thing.
Oh, yeah. I was just going to say that.
Some people are good. Some people are good at working in large organizations. I'm not one of them, because if I see something and I want to do it, I want to do it now. So I left the Emily program and started the Center for Evidence-Based Treatment, which was more of a broader, which is a sort of a we treat a broader level of issues. At the Cleveland Center for Eating Disorders, obviously, we treated eating disorders as the primary issue. And because it was in the title, those were the people we got that would come to us. But I was really interested in making sure that there were evidence-based interventions for all kinds of problems that were offered to clients, patients, whatever you call them, people. Sometimes I say I don't like the word therapy because therapy suggests there's something wrong or broken. Like I try to think about myself as a consultant. Like I know about how to help you with this problem that you have. Let me consult to you about it. That's another discussion.
Very much, yeah.
But that there are evidence-based interventions, and it would make me crazy to hear these stories. You know, I have 3 kids myself. My kids are adults at this point. They're 28, 26, and 22. But I would hear parents and other individuals talk about going to therapy for X problem, and it would hurt my heart when I would hear what was happening in those therapies, which was often a nice person talking to them about their week and not a structured intervention that was designed to help the problem that you have. And I'm not saying that there aren't people who are helped by that, because there are some people who that would be the right thing for them to do. But it is more often than not, if you have an anxiety disorder, if you have major depression, if you have an eating disorder, we know there are evidence-based approaches that are actually pretty time-focused that can get you feeling better and get you back into your life or sort of having a better life in a much more time-efficient way. And so when I started the Center for Evidence-Based Treatment, I was interested in offering evidence-based interventions for a multitude of problems. And I think that the corollary to that is, you know, how do you know what problem somebody has? I could do a lot of consulting with other clinics, you know, small clinics, large clinics, and it never ceases to amaze me how people decide who someone should see, you know, basically at the front door. So the way that we do it is we do a pretty extensive assessment where we'll send you a battery of questionnaires, all kinds of problems that you might have, and then we do an interview, and then based on that, we decide who's the right therapist. Not just because somebody has an opening makes them the right therapist, or even just because what you told me on the phone you're struggling with, then I match you with the right person. Because the thing that I would see happen over and over, and I'm working to do some research on this right now, is that when I switched from running a clinic called the Cleveland Center for Eating Disorders, where I knew that people had an eating disorder when they were calling, to the Center for Evidence-Based Treatment, people would call and they would say, I'm depressed, I'm anxious. And then because we do this assessment, we would find out, oh, wait, and they have an eating disorder, right? But had we just relied on what they told us at intake, we wouldn't have known that. And so the Center for Evidence-Based Treatment is committed to a pretty hefty evaluation where we try to figure out all the things that might be going on, and then we match you with the right intervention for the problem that you have. And I feel very passionate about this. In fact, I did a consultation just the other day with a clinic, and part of what this clinician was describing was working with this patient who said that, and he did have depression, and she's now 2 months into treatment, and she finds out that he has a pretty significant bulimia nervosa, which, had you been asking that at the front door, wouldn't have been a surprise.
Yeah.
So that's my diatribe about that.
Yeah, eating disorders, you know, they never stand alone. So back in end of last week of February was Eating Disorder Awareness Week, and the center's theme for that week was Break the Silence, Embrace Recovery, Addressing Eating Disorders in Midlife. And it focused on women 40 years and older and their experiences with, you know, hormonal changes, their body image struggles, and the societal pressures of, you know, what they should look like. Many are going through divorce or other relationship issues. So can you talk about this underserved group of people?
Yeah. You know, I think there's a couple things there. You know, as a field, we've gotten better at understanding. You know, when I was first in training more than 30 years ago, I think we mostly believed that eating disorders were a problem of young Caucasian girls. And we know that that's not true anymore. We know that eating disorders impact people of color, they impact men. And we have gotten better, I'd say maybe only in the last 10 or 15 years, at acknowledging that women in midlife also struggle. And that this is a group that has been, I wouldn't say ignored, but I think, it's funny, I was just in Australia at the Australia-New Zealand Academy for Eating Disorder meeting, and which always makes me happy to be with other eating disorder professionals, because we can really deep dive into, areas of interest. And that's what we do at the happy hour, not even during the conference. It's geeks talking about the things that we're interested in. And one of the things that one of my colleagues said is, I go, who is a middle-aged woman, I go to the doctor, they ask me about smoking, they ask me about drinking, but no one ever asks me about my eating. And I was really struck by that. To think about how we have to educate our medical professionals. But in terms of, older women, I don't think that people have asked. And we're now getting better at recognizing that this can be a vulnerable time, right? So we know that in inpatient units, 25% of admissions to inpatient units these days, most recent data, are 45 and older. We need to pay attention to this. Wow. And I think that these women tend to fall into three groups. These are, some are people who've had an eating disorder since adolescence, and maybe it hasn't gotten better. Some of them had an eating disorder that was clinically significant, recovered, and then menopause because of the things that you mentioned. There's hormonal changes, there might be life changes, and there's a relapse. And there's also a small portion of people who have onset later in life, without having had a history of frank eating disorder. And again, as a field, we need to pay more attention to women at this age.
Yeah, and being the male here, there's men out there that in midlife and going on with everything that's happening to their bodies, and we are, we inherit so much from our parents, and I look at myself and my body and my dad, and as you get older, and again, there's a lot of societal pressures on, just trying to find clothes to wear, for people that are older and stuff. So yeah, it's certainly affects
listen, I
men
appreciate
too.
your highlighting the men piece, because it's absolutely fair. I was thinking more about in relation to menopause, but what you just said is dead on as well. Of course, it impacts men as well.
Yeah.
It's gravity. Gravity's a problem.
Yeah.
Our bodies are a blessing, but we are so much more than just our bodies, and that our bodies are functioning. There's so much to be grateful for, and just to be realistic. And you hope as you get older that you have enough self-confidence to be able to wear your body beautifully, whatever shape or size it is, because it's our body and it's a miracle. They're all miracles, but there's a lot of things that can interfere with that, and
for sure.
And I love how you call yourself being a consultant. I really like that. So, So I also understand that you and the wonderful Dr. Anita Federici are great friends and colleagues, and that you're now doing trainings together. Can you share more about your friendships and your wonderful collaboration?
It's funny. I think I talk to my kids about this not infrequently, finding your people. How do you find the people who think the way you do, who have the same values, who are interested in what you are interested in? And for me, I've actually never gone to a high school reunion. But I do go to the Academy for Eating Disorder meeting religiously, because those are my people. And Anita is one of those. I met Anita in I want to say I met her in 2006 maybe, and we got her to come and work with us in Cleveland in 2008. And she was here for, I think, a good 3 years before she went back to Canada. And so if you think about when in the story, I started developing MED-DBT, in I'd say, 2001. So Anita was there early on, and we did a lot of thinking together and a lot of sort of adapting the treatment together. And then she went back to Canada, and we've always, just because she's just so awesome, and she's a friend as much as she is a colleague, we've obviously stayed in touch. And we do trainings together. We have a very, I think, similar training style, so it makes it super fun to do trainings with Anita. And then we decided to write this book, Lucene, we need, there needs to be a book out there. We need to write it. I was like, oh, okay, Anita, sounds good. And frankly, the best part of writing the book was that we had a scheduled meeting every week for the last year and a half. So I knew that I would get to see her no matter what. And we would talk and catch up and obviously work on our book. And that was probably one of the best parts of writing the book, was getting to spend time working with Anita.
Okay.
Let me add one tiny part to that is we are, so as part of that, and I think both because we want to get the word out and because we enjoy working together so much, we're going to be putting together a sort of training series that's related to the book that we're going to publish later this year. And that'll be more opportunity for us to get to see each other, which is great. That's one of the benefits of Zoom, the whole sort of internet world that happened because of COVID. It's one of the positives is, being able, in fact, even do this.
Yeah, for sure.
Yeah.
I'm going to skip to a later question in terms of talking about the training that you have. That's a big part of what to me seems to be happening with CEBT, that you do a lot of training. And it also, to me, it seems like there is kind of this rumbling in terms of expanding the understanding of MED-DBT in the eating disorder field, kind of across the U.S., and also mentioning you have a summer series coming where you're going to talk about this. So do you mind talking more about that? The series that's coming up, your professional development opportunities, and how this movement may expand more broadly.
Yeah, thank you. We do. So Anita and I have a summer series. We sort of sat down and thought about, if we were starting to let people know more about, because we each do our own trainings and have been for years. And as we're thinking about pulling this together and what are the things that people need to know? What are the things that, when you're sitting across from someone who has an eating disorder that is sometimes a life-threatening eating disorder, meaning sometimes they need to be medically hospitalized because they're medically unstable, who might also have suicidality and self-harm and or substance use and depression and anxiety, and difficult relationships, where do you even start, right? Mm-hmm. And that's often the problem that I think faces people who try to work with individuals who are multi-diagnostic. So okay, what are the topics that we think might be most helpful and strategic to teach therapists out there? So we started with, understanding. So DBT, one of the things I love about DBT is it offers a structure for understanding what to work on when. It's not just because I feel like this is a problem, I as the therapist feel like it's a problem, or the patient told me it's a problem, but there's a structure. So you have to work on what we call target 1 behaviors first, which are anything that might result in you being dead. So if you have a life-threatening eating disorder or you're self-harming or suicidal, that has to get addressed first. That doesn't mean to the exclusion of other things, and perhaps, again, that's a longer story. But so being able to teach people, how do you think about it? How do you incorporate eating disorder behaviors into this target structure? That was the first thing that we knew that we needed to talk to people about. And then issues around motivation and commitment. You know, I was talking to somebody the other day who was saying, well, eating disorders are so much harder to help people with than anxiety. Well, yeah, because most people want to get rid of their anxiety. Most people don't like their anxiety, but most people with eating disorders are ambivalent at best about, you know, they want to feel better, but they're not sure how much they want to get rid of their eating disorder. And so working around issues of motivation and commitment have to be part of the treatment. And then helping people think through clearly what we call in DBT behavior chains. And if you're familiar with CBT, we would call that a behavioral analysis, but like helping the therapist learn how to look at all the links in the chain that result in someone's behavior, and then what do you do about it? So that's our summer series, where we're starting out, you know, a day in May, June, and July, where we're going to teach people about these components of MED-DBT.
Well, I think one of the most wonderful things about DBT in general is it meets people where they're at, and whatever behavior they had beforehand, it's not poo-pooed. You know, it's, well, you know, that's something that served you, but it's no longer serving you, and you want to make a change. And, you know, and what you're doing with the MED-DBT is working with that motivation and the goals in mind. And I think those are the things that really can keep people on point, because I think that if people aren't positive enough when they're working with a client, that they can't see the future, you know, they don't think about it. They're so in the now that they can't get that far. So I think just by honoring where they are now and praising them for being there and working on goals together, it just makes the shame dissipate.
Yeah. No, I really appreciate that. You really understand DBT, Linda. I can hear that in that comment for sure.
It's so validating. I think it's just a wonderful form of therapy.
Yeah.
So there's a lot of treatment centers throughout the country, and you know they all say they have CBT and DBT, but they don't list MED-DBT as a treatment. So, and I know Anita got a lot of pushback in Canada about this not being quote unquote evidence-based or whatever and stuff, but you're training people all around the world. So,
but it is evidence-based, just not specifically for eating disorders.
Well, let me say this. So again, as a research psychologist, which are my roots, it does not have as much research as other things. Now, that being said, I would argue that even standard DBT does not have research evidence for the people that are being treated in those eating disorder facilities. There's not, but it is common for facilities to try and incorporate aspects of treatments that are popular into their treatment, into their modality. So it's not. So I guess there's two pieces. Number one, I would say that MED-DBT does not have as much research as, for example, CBT. It does not. And then the type of DBT, I'm splitting hairs here, but the type of DBT that does have research is not for the people who are in those residential facilities. It's that Deborah Safer model, which is phenomenal. But again, so I think it's a complicated question, Jack, and I appreciate your noticing it.
Yeah, no, I mean, because and again, these treatment centers are needed, you know, we need them out there, but the cookie cutter approach that they're doing with so many people.
Well, I think they're trying to get away from that, but I think the models just need to change. I mean, I think they're all, very well intended. But you hear when people are finished with their treatment, they will tell you the things that worked and the things that didn't. And they're pretty linear. I mean, they're pretty, and they just need to be listened to.
I mean,
all.
it can be, it's very subjective. I mean, what you're going to get from the patients, but when there's so many saying the same thing, that, what worked and what didn't, people need to recognize that and work differently. So, but that's why you don't like to be told what to do, and so, but so many of these centers are told what to do. So,
Well, that's the truth. And I will say one other piece, like if you, which is splitting hairs, but if you have been to a residential treatment facility and you have been exposed to DBT, that's phenomenal. But my concern, I have seen many people who come out of a system and haven't been oriented to the fact that they did not actually receive the whole treatment. They received, there's just not humanly possible, even if they were there for 2 months. You can't receive the whole treatment. It's a minimum of a 6-month treatment with a weekly individual DBT therapist, and being in a skills group, and having phone coaching, and that your treaters are part of a consultation team. It's just impossible to do in a higher level of care. And so having people, because I've had people come and say, well, I've already had the DBT. It didn't help me. Well, no, you had an aspect of DBT. Mm-hmm. Let me educate you about what it means to do the full model, and then you can decide whether or not, and that's part of motivation commitment, and then you can decide whether or not you're willing to make a commitment now to doing the full model.
So are you getting a lot of people from the United States wanting this model?
Absolutely. Yeah. I think that, part of what happens because MED-DBT and our center in particular is known for rising to the challenge of helping people who haven't been helped in other places, in other situations. I think we get referrals not just from people themselves, but even from providers who are like, I'm not helping you. You need something else. Can you go and try this? So we are getting quite a few referrals specifically for MED-DBT.
Can you talk a little bit about your recommended treatment plan for somebody? Because when you just hit on 6 months, that, and I think it's that awareness of there is not an easy fix. It takes time. It's a process. And how do we get there? Can you share a better understanding of that?
You mean like how do you explain that to somebody?
Yeah.
Is that what you mean by that question?
Especially, and parents too, because so many parents are just, they put their children in treatment centers and they think, well, when they come out, it's going to be better.
They're going to be healed.
Yeah, sometimes
2 weeks into treatment, they're like, oh my God, they hate it. They want to come. I mean, it's such a common thing. And what we're talking about. And it's like, oh, whoa, wait, this is a process.
This is why I'm so grateful for individuals like you guys who are, have had your own experience and are talking to people and sharing it with them. Because I think sometimes it's almost more meaningful coming from somebody who's been through it than it is from the professional. Because I don't know, and remember, I think the other thing is when you're in crisis, you don't always hear well, right? Like you're in crisis and someone might say to you, it's going to take a long time, but you didn't hear that because you're still thinking, I'm going to send them to that treatment facility and they're going to be back in a month and it's all going to be good. But we know differently because we've been there. Whether we've been there personally or professionally, we understand that this is a process and that it is, unfortunately, depending on what aspect of the research you look at, the good news is that people do get better. The bad news is it sometimes takes a long time. And the evidence-based interventions, I don't know of one that takes less than 6 months, and it's 6 months is kind of a minimum. So FBT is 6 months to a year. DBT can be 6 months to a year. Your standard CBT for anorexia takes a year. These are not easy fixes. And I think being able to provide psychoeducation to the families, and again, which is why I'm so grateful for your voices in this, is part of it. And again, as a parent myself, I get that feeling of I just want this to be better fast. And it's not the reality. And so, and that's why in DBT, we have something we call orienting. It's not orientation in the same, like, you get orientation before you start school. It is a similar idea, but like, let's lay it all out before you start. Like, you need to understand what you're committing to before you commit to it. It's not enough that you just showed up for your appointment and said you wanted to. I want you to really understand what you're committing to before we start this process, both how much work it's going to be and how long it's going to take. And that may put you off, but I would much rather you know that before we get into it. So it's going to save us both heartache. So I appreciate that question a lot, Ellen.
So it's incredibly important to educate clinicians in different modalities, but I think this is one that is going to really rise to the top. But it's also so important to educate families and communities. And I always say, if you're fortunate enough even to get the best level of treatment for the right amount of time, the rubber hits the road when you get out of treatment. And I think families are very well-intended so much of the time, but everybody says things wrong some of the time. But
for sure, people with eating disorders are usually very sensitive, and there's always better ways to learn to communicate. So I hope that this model can be used for family members too, especially, going forward when people, whether they've needed residential treatment or not, just to help their loved ones stay on the path, whether it's their spouse or their sister or, children. It's just so important for people to feel heard and understood and not judged. So I also imagine that it's been very challenging for you to work with so many different diverse populations in the U.S. and beyond. And I'm sure there's challenges for you as a researcher and a clinician. So you want to speak to those things? Yeah, so first I want to say first of all, I appreciate the question and the opportunity to say how passionate I am about including families and loved ones. There is not a case that I can think of where I think, oh yeah, don't include your family. And I don't, and I mean, again, you said we all say things. You ask my kids, I'm sure they could give you plenty of examples where I was not as skillful as maybe I could be, because we're human and we're not perfect. And any parent any loved one that's true for, and I don't think there's a user's manual where you go home. It's like, when you go home with a kid or you get in a relationship and then there's someone has an eating disorder, like you said, they are often very sensitive, and things that would normally not upset somebody does upset them. That's just part of who they are as people. And our job is to not necessarily treat them as fragile and never go there, but to learn how to be able to have those conversations in a way that's functional. It makes me, I don't know what the right word is, but angry comes to mind as a minimum, when I hear stories about people being in treatment facilities and where the family is not included, more than not included, is excluded.
Yes.
And not able to participate. And so we sort of, I feel like, go above and beyond around including families. So when there's a young adult who hasn't gotten better, I will not, with maybe one exception, because I can't remember one, but I'm sure it exists. If you're a young adult, your assessment needs to include your parents or your loved ones, because often we are not good historians of our own care in the first place. And when you've been through multiple treatment experiences, we need more information about you as a person and the things that you've been through that are not just from your perspective. So I almost always include families in that at a minimum. And then MED-DBT, if you are a kid, we're marrying FBT and DBT. And so your parents are included because, and I will say, I know that there can be some feelings about FBT, but we do a lot of including parents in terms of the solution. And we also do strict FBT, but we also do more flexible approaches as well. But so parents are always included, and then parents are part of the multifamily skills group where they're learning the same skills that the kid is learning. Now, that's just baked into the treatment model. When you have an adult whose parents are not, if you're 20 and you're in a skills group, your parents aren't in a skills group because it's not multifamily in the same way that you are when you're an adolescent. But in order to accommodate for that, we do have several parent-focused groups where we teach parents both DBT skills and this notion of, you may be familiar with a treatment called SPACE, which was developed by Ellie Leibovitz at Yale, which is for a treatment for anxious kids. And there's a construct in it called accommodation, where parents who are loving, caring, devoted parents are doing things to not make their kid anxious. Because they're worried about the impact of that anxiety on the kid. And so we teach parents about the notion of accommodation, and we try to help them. And this happens a lot in eating disorders. I don't want to ask them to do that because it's going to make them upset and maybe they won't eat. I don't want to have them face this food because that's not a comfortable food for them. Should I not even offer it to them in the first place? So we teach parents about how to approach these things that are difficult for them and difficult for their kid. And I'm saying parents, but it could be loved one. And that's part of this other arm of treatment that we do when we have young adults who work with us. We include their parents in that way as well.
So
can we just have a cheer and just scream from the rooftops? Oh my God, this is it is so important.
Yeah.
It's so important in talking about training the parents and loved ones and family. It's essential. Oh my God, you are an inspiration.
Music to our ears.
Yes.
Sure.
So with the HIPAA laws that are out there with, somebody's over 18 and can make their own decisions.
Sure.
Do you demand that the clients have their parents involved? And if they say, no, I don't want my parents involved, how do you get around that? How do you handle that?
So this is an interesting conundrum. And I would say, I'm going to warn you in advance, I'm going to talk around it, but I am going to answer your question. So it is standard for us to say, you're living with your parents are involved to some degree. And if you don't want to do that, then I'm not sure we can offer you what you need. Now, there have certainly been people where they say no to start and we say, all right, listen, we'll see you for 4 to 6 times and we have to talk about it. And if you show me you can do every single thing that you need to do without your parents' involvement, then we'll figure out how to communicate with them, but we won't involve them. And inevitably, it's almost impossible for that to happen. If that happens, fabulous, you're doing great. We're not going to push it. If you don't, then you're going to agree that your parents get involved. Okay. I have to say, I can't really even think of an example where we've had to terminate treatment because of that. We almost always find a way for now, it depends on what you mean by parent involvement, right? I'm not saying it's parent responsibility, but at a minimum, communication about what's going on. We do something called a communication log where it's like, okay, listen, we just met. You're meeting with your doctor. Let's talk about what things you're going to share with your parents. And you need to tell me what you're sharing with your parents and send an email with me on the CC it so that we're all on board because we know how these things go. Well, I told them this and it's only part of the story. So we have a way that it's baked into the way that treatment goes, regardless of whether you're 18 or 88.
Okay. I just want to go back to a question I didn't get to ask about. So, who was one of your most, or who your most staunch supporters when you started at the beginning of this?
Ooh, that's going to make me verklempt. So I have to say, so Marcia Marcus, who was really my mentor, I come from a family. I was one of the first people to go to college, right? Like in that my parents' generation, people didn't go to college. My cousins and my family, sort of went but didn't go away. So like when and there's nobody on my side of the family who has an advanced degree. So that might not be true. Maybe somebody has a master's degree. They might be listening. I'm going to be in trouble. But so when I went to graduate school and I met Marcia became this model for me, both of, first of all, she is just a lovely individual. I mean, like, there's nothing, I've never heard anyone say anything bad about Marcia Marcus. And then she mentored me both academically and professionally. And I remember, and so that was during graduate school. And then when I came back and I wanted to start applying DBT to the treatment of eating disorders, I remember having a conversation with her. I can picture myself sitting at my desk here in Cleveland and calling her in Pittsburgh and saying, Marcia, but I want to do this thing, but there's already this other model that Deborah Safer and Christy Telch are doing. Maybe I have to use that. And she was like, Lucene, stop. You can do what makes sense to you. I want you to follow your own path. And it was so meaningful to me because that was when I felt like using standard DBT made more sense than using that other model, but I needed that sort of guidance and permission, and she gave it to me. And then she was she continued to be a mentor and continues to be a mentor for me, both again as a role model, as a person, and that's hard to find in academia. I don't know if you know that.
Yeah, I imagine
it's not always easy to find, but not only just as a person, but as an academic as well.
Yeah. I imagine it's there's a lot of egos involved out there, and I like the fact that you didn't want to be called doctor and that you are a consultant to your people. So yeah.
Well, we're almost out of time here. Ellen, did you have something you wanted to ask?
I'm good.
Okay.
We have
Good?
covered so much.
Okay. So can you tell us about the MED-DBT conference coming up in September 2025? I know our audience will want to hear about that.
Yeah, I am so honored. So this has been I first want to say that I'm not the person who is organizing this. This is Anita Federici, Shelley Sinclair, who's in New Zealand, Kim Claudette at UCSD, and Charlotte Thomas, who's in Portland, who are all people that I've worked with over the years. They're really the ones who have organized this conference. It's a virtual conference. It's really a natural extension of both our research and our clinical work. There's a larger community, literally internationally, of people who are interested in this model. And there's not been a place for us to be able to gather and talk about what we're doing. So they put this conference together. And if you go to the website, the abstract for the work. So if you want to present, if someone hears it and they want to present something, abstracts, the request for abstracts is up. There's also going to be a research or lightning round, and that's up. The general schedule is up, and I'm honored that I'm the keynote speaker. It really means a lot to me that, to see this as, where I am in my career, to be the keynote speaker of this inaugural conference. So I'm super excited about it.
It sounds fascinating. Wonderful.
I'm super excited because this will be the first opportunity to really launch this on in an expansive way, so that many clinicians can have access and then follow up with continuing education.
Exactly.
Lucene, this has been amazing. Thank you. I know how busy you are, and I really thank you for reaching out and being with us and sharing your precious time with us. And there's so much to be garnered from this interview. Thank you. Thank you. Thank you.
Yeah, it's been my pleasure. And again, as I said, I'm honored to be a part of this conversation and so grateful for your voices being part of the mix. I think clinicians in general need to talk to, people who have been there themselves. And it's necessary and important work.
Yeah, I mean, that's why we keep shouting from the rooftops and doing what we're doing. We're all about recovery. Unfortunately, our daughters didn't recover, but so many of these new ways of treating people, I wish they were there back.
Absolutely.
10, 15 years ago.
Yeah.
We need to expand options and be more creative and really address those gaps of where we're not meeting people's needs. And this is an expansive conversation, and we are just thrilled to have you talk to us today.
As a pharmacist and for 45 years, we don't treat high blood pressure the same for every individual.
That's right.
We start with, one drug, and if that doesn't work, we add something else, and the same with diabetes and all, physical things that are treated differently for the individual. And we just need to understand that with all mental illnesses, they need to be treated more individually. And it's starting with people like you, and there's great people out there, but it needs to be more in the general.
And Jack, if I may add one last thing, which is the other thing in your description, if the first drug didn't work, we don't also give up.
No.
We keep trying, and we keep trying different things. And I think that's the other way, the metaphor that we need to make sure that people hear. Like, if the first thing didn't work, okay, well, let's try the next thing. And it may be that we have to get to the 15th thing, but we're not going to give up.
Right.
Yeah. The more tools in the toolbox, right?
Yeah.
Well, this has been amazing. Thank you so much, Lucene.
Yeah, thank you.
Extend our sincere gratitude to you and to our listeners. What an important conversation. We also need to thank Rockvox Recording and Production and Scott Fitzgerald, our remarkable sound engineer, for his exceptional production of our podcast and so much more.
Please rate, review, share, and subscribe to this podcast, Once Shattered, Picking Up the Pieces, on whichever platform you are listening on, and check out our YouTube channel. Learn more about Linda and Jack Mazur, the founders of the Emily Connection, and their beautiful book, Emily, the Story of a Girl and Her Family, Hijacked by Anorexia, available on Amazon.
And learn more about our colorful co-host, Ellen Bennett, and her nonprofit organization, K&B for Answers, and the great things that they are doing and have been doing for years. The discussions we have with all our guests are incredibly important as they emphasize the importance of mental health for every one of us. Thank you again, listeners.